During this hearing, witnesses will share with us how VA works hand in hand with private doctors and providers to meet veterans' specialty care needs throughout the VA community care program. Data show that veterans like and want community care, just as they like and want their VA healthcare system. Polling has shown that Americans want veterans to be able to access shorter wait times and drive times to get their health care. Through the Mission Act, Congress has closed the gap that was crippling the delivery of care by the VA and oftentimes leaving veterans behind, stuck in line, and waiting for an appointment. This was especially true for specialty care. By virtue of being in the community, these providers are closer to veterans and their homes than a brick-and-mortar VA facility. That can mean shorter wait times and drive times for veterans. Through the Mission Act, the VA Community Care Program created new opportunities for more resources than ever to serve veterans. Veterans enjoy shorter wait times and drive times for specialty care appointments because VA is allowed to cover specialty care in the community. Veterans have more specialty care through VA because of community care, not less. Three key indicators today and on the horizon show that the VA will continue to rely on providers in the community to meet the moment for specialty care for veterans. First, demand will increase for all specialty care needs as more women use the VA for health care. By 2040, the VA estimates that women will make up 18% of all veterans. More women veterans means not just an increase in female-specific care, but an increase in specialty care services overall. Second, VA's workforce challenges mirror those of the healthcare industry as a whole. There is a national shortage of healthcare professionals, especially for physicians and nurses. The VA recently identified shortages for clinical roles like psychologist, medical technologist, diagnostic radiologic technologist, which is the same in the private sector. And this is true across all VA facilities, even though this committee and the Veterans Affairs Committee has increased pay to providers within the VA healthcare system. All of these roles play a part in, if not directly, provide specialty cares for veterans. The higher the ratio between veterans and healthcare staff, the more veterans will need community providers for VA-covered specialty care. Third, and finally, the VA expects significant changes in demand for care in general, including specialty care. The VA projects major shifts in physical space demands for hospital operations by about 2030. Estimates range from an $850,000 decrease in needed square feet in New Orleans, Louisiana, to a $2,500,000 increase in needed square feet in Orlando, Florida. So having facilities where they're needed in accordance with the demographic shifts of the country, sometimes we're far behind where that movement occurs. These are but two of the many estimates projecting dramatic increases and decreases in demand for physical space across the country. And one of the reasons we introduced the Chip-In Act in this committee, as well as increases for funding infrastructure within the VA. The VA also projects highly variable demand in different facilities across different types of care. I hope you'll bear with me as I explain the numbers which paint a compelling picture of the veterans' healthcare needs. The VA expects a 50% growth nationwide in outpatient, primary, and specialty care combined. Relatedly, the VA also expects a 13% decrease in inpatient acute medicine and surgery nationwide, and this too mirrors what we see in all healthcare sector. But the VA expects an increase for inpatient acute mental health. That means more demand for psychiatric services at a hospital for severe mental health crisis. And as we know from hearings here in this room, the VA did not consider residential mental health care or residential substance abuse to be part of the Mission Act. So that's a lot of variation. Even within these numbers, the VA expects significant differences in demand from region to region. For example, with inpatient acute mental health care, the VA projects a 6% decrease nationally in demand for inpatient acute mental health. But when we dig another layer deeper, we see that the VA expects anywhere between a 19% decrease to a 14% increase across different regions of the country. I care deeply about mental health resources for veterans, and I know that the VA will continue to provide valuable in-house care to veterans who need it. But with so many variables, the VA cannot expect in-house care alone to meet different demands from different communities. Veterans need inpatient mental health care when they need it and when they're in crisis. Veterans need specialty care when they need it. A condition in need of treatment doesn't wait for the facilitatory infrastructure to be built and to catch up. And as a physician, I know this reality firsthand. And a veteran should not wait for treatment when community providers are already available to meet a need. To best serve veterans, the VA should pursue whatever gets quality care to veterans when they need it. The VA serves all veterans when it opens the door to community providers equipped to care for veterans at the right time, at the right place, with the right treatment. As a 24-year Army veteran and physician, I'm focused on working in lockstep with the administration to ensure that this happens. The future of veterans' health care depends on it. I now yield to Ranking Member Brownlee for any opening remarks you may have.